Welcome back to the Move Professional Podcast. So today I'm going to ride solo as I discuss neck pain and other similar presentations. Again, this presentation will be good to view on YouTube because I'll be going back and forth between the Essential Anatomy app to show some of the relationships of the anatomy in the neck and around the neck. And that's going to be really important as we start to discuss the different presentations of pain. So first, what is the neck? It's often referred to as the cervical spine, and it's basically the first 7 vertebrae of the spine as a whole. The first joint is the articulation of the skull or the occiput and the first vertebrae, and the neck is often discussed as the upper cervical spine, which is the first 2 vertebral levels, C1, cervical level 1, and cervical level 2, and the lower cervical spine, which should be cervical level 3 through 7. And the distinction is often made for 2 reasons. One, the way that we use the neck functionally is we often have to have our head up and gazing in the environment. So the lower part of the neck will rotate or flex in usually a different direction than what we're doing with the upper cervical spine, because we have to use the upper cervical spine to lift our eyes and look sometimes in different directions than the rest of the neck is positioned. The other major thing is that the cervical level 2, which is often referred to as the axis, has a piece of anatomy called the dens, which is a pivot point for rotation. And so you get quite a bit more rotation, up to about 50%, coming from just those first 2 levels because of this pivot point for rotation. So when we look at the neck, it's important to functionally separate it out between what's going on in the upper cervical and the lower cervical spine. So what surrounds the neck, we'll take a look at some of the relationships between the shoulders and the scapula, the shoulder blades in the neck. The thoracic spine is right below the cervical spine. We'll look at some nerve roots and where they're located in relation to the joints of the neck. And then we'll look at an extension of the nervous system into things like the brachial plexus, the peripheral nerves, such as the median nerve, the ulnar nerve. Some injuries come from there. The sympathetic nervous system, we talk about that from a perspective of it's the fight or flight response and all the things that basically come from that stress response. But there is an anatomy to that. So we can look at some of the ganglion that are related to sympathetic nervous system activity, and you'll see how related the stress response is to neck pain and the function of the neck. And part of that is because we look at some of the other anatomy, the veins and the arteries. There's major veins and arteries right in the neck: the jugular vein, the carotid artery, the vagus nerve, which is a nerve that often gets discussed in relation to relaxation, and the parasympathetic response that runs through the neck. So we'll look at some of this in the anatomy app, and also the vertebral artery, which is the blood supply right into the brain, which is very important, runs right through the neck. And then finally, what surrounds the neck: muscles. We'll look at this in layers. So you get your anterior front compartment. Superficially, you have a muscle called your sternocleidomastoid and your platysma. And then you have your suprahyoids and infrahyoids, which basically super means above the hyoid bone. I'll show where that is. The infrahyoid just means below that hyoid bone. Those are deep muscles on the front of the neck. And then your prevertebral means basically on the front side of the vertebrae, you have your deep neck flexors, which are important neck stabilizing muscles. Your paravertebral, or your lateral muscles of the neck, which would be your scalenes. Those are going to be important because they attach to the first and second rib. So they play a role in some neck pain in just based on their attachments. So I'll show you those. And then the vertebral muscles are intrinsically, they're basically the ones that go on the posterior backside. And we have, they come in layers. So we'll look at that. Splenius muscles, the suboccipital muscles, transversospinalis, interspinalis, transversare, all have fancy names, but they're just basically describing where their attachment is in the body. And then the extrinsic, which means, again, the more superficial type muscles on the backside, the upper trapezius, which most of the audience will be familiar with, the upper trap, and then the levator scapula. These are muscles that definitely play a role in pain. And you'll see that it doesn't really make sense to make any one muscle a culprit when we're talking about pain, because things are too layered and too intertwined to really have one muscle be the blame. However, you can see that some attachments can be very common to common pain presentations. So some of the muscles, it's good to know where they are. It's good to know how they're layered. So let's take a second now to look at some of these relationships on the anatomy. All right, so we'll start by just looking at the anatomy of the vertebrae, cervical spine. So this first vertebrae is right up here called the atlas at C1, and it makes its articulation here with the occiput or skull. So that would be the first level of where the cervical spine starts. And then we have the cervical level 2, and here's the dens here I was talking about before. Let me isolate this out so you can see this pointy little finger that sticks up there. That's at pivot point, and there's so much rotation that comes from that C1, C2 because you can see how there's a pivot point around there. So let me remove it. Right here, that's its own joint where this dens attaches to the first cervical vertebrae. And you can imagine how that's like a pivot for rotation for the head to turn side to side. All right, and then we have your C2, C3, C4, C5, C6, and C7. So all the way C1 through C7, that makes up the cervical spine. Below that, we now start to look at the thoracic vertebrae and the thoracic spine. And that basically just begins where the rib cage begins. So the cervical level 7 is above the rib cage. Thoracic level 1 starts as the first rib starts. And that's going to be important again with all these relationships to pain in this general region. We'll call it neck pain, but in many ways we could be calling it first rib pain. We can be calling it upper thoracic pain because everything is so intertwined in this region. So it's good to appreciate that. All right, so it's a good point to add the nervous system into the mix here because we could see where the nerves come. And a lot of times when we hear different neck pain presentations, we think of them as combined with maybe pain down the arm or some type of pinched nerve presentation. So get a sense of what that means. So if we look here, this is probably the best example, the most visible example is of cervical level 6 nerve root. So every vertebral level has a nerve root that comes out of it. So we can come all the way back up to here. We have C1 and C2. So the nerve root coming out of there is the C2 nerve root. So above that would be the C1 nerve root, and that would be between the occiput and cervical level 1. And then each level has a nerve root that corresponds to it. So down here, we're looking at C5, C6, C7, and then there's actually a C8 nerve root, even though there's not a C8 vertebrae, and that's the nerve root between C7 and thoracic level 1. All right, so these nerve roots come right out of the spinal cord. Broadly, coming out of the nerve root, we can go into something called the brachial plexus, but the brachial plexus has several branches. So we have the trunks that come off of the nerve root. And then if we follow that down, we have the divisions. We're following the divisions down. We get into the cords of the brachial plexus. And then from the cords, we go into what are called the peripheral nerves. And then some of the peripheral nerves are more common to people that don't have as much of an anatomy background. So many of you may have heard of the median nerve, which runs through the front of the elbow and then down into the wrist. And that is going to be the nerve that's involved in carpal tunnel syndrome. So if we follow that median nerve down, we can see it right through here. And if we add some connective tissue, this is called the retinaculum. That is basically the diagnosis of carpal tunnel syndrome, where this is your carpal tunnel under this retinaculum that gets caught up or it can compress the median nerve, and that's what leads to the symptoms of carpal tunnel syndrome. But this median nerve runs all the way through the upper extremity, basically. So oftentimes it can also get injured closer to the front of the elbow, as we see here. Another nerve that's pretty commonly, at least affected, not often injured, is the ulnar nerve, which runs behind the kind of funny bone area. And if you ever hit your funny bone, that becomes the ulnar nerve that we're feeling through here. All right, but all of that stems from this brachial plexus that comes out of the nerve root. So really the nerves that we talk about that are getting injured, again, sort of like the muscles, they can't be really isolated or it's very rare that they're isolated from an injury perspective. But you can see sometimes their location can be in a point where it's easy to compress. And with the ulnar nerve especially, it just happens to be running through like a little tunnel where it's easy to just hit that particular nerve as it runs through that tunnel. And then that gives us the sensation that usually goes to the pinky side of the hand, where the median nerve goes more to the thumb side of the hand. So that's how we can differentiate where some of these nerves are being affected throughout the body, but they're usually coming out of the neck. So neck pain can be connected to some of these pains that you get down the arm into the hand. So if we look more on the front side of the body, here we could start looking at some of these nerves, the nerve ganglion. And these ganglia, I think, are important to understand their relationship to pain in the body, because these are going to be related to our fight or flight response or sympathetic response. And they're just right on the spine here. These big ones here are the celiac ganglion, which have much to do with digestion, and they're going to be connected to our rest and digest response. If we move up here a little bit, but you can see up into the neck, there's some ganglia up in here. This is your middle cervical sympathetic ganglia, and then down here we have the inferior cervical sympathetic ganglia. So we have these ganglions which are directly related to our fight or flight or sympathetic response, and they're very much right in the neck with the other neurology there. So if we get rid of some of the nerves, we're going to go into some of the major veins through here. So right through here, this is the internal jugular vein. You get that damaged and you're not going to live very long. The arteries that run through there, you have your carotid artery right through there, common carotid artery. So arteries and vein, very vital to your survival, right? These are major arteries. So there's so much in the neck that is vital to your survival that there is very much a protection response within the neck with all of the anatomy that's running through there. So that's what's really important to know when you're looking at this anatomy. You certainly don't have to memorize any of this, but as you're looking at how interconnected everything is, how close together everything is, and how much the stuff that is running through the neck ties into our survival, kind of runs right into our major systems of the body, our circulatory system, our fight or flight response, and ultimately our spinal cord and the higher levels of the spinal cord that are responsible for our motor movements and even our breathing function. It all runs right through the neck. So there's such a high level of protection going on in the neck that we don't necessarily recognize consciously, but it's what often is responsible for chronic pain within the neck. And the last thing that we'll look at, some of the arteries here. So we also have this vertebral artery, which is important. If you just look at the anatomy of the cervical vertebrae, there are these holes. If you look down through here, basically these foramina, that's where that vertebral artery runs through. So that can be important. Sometimes that will get affected with adjustments to the neck, or with the neck having pain for long periods of time. If there's pressure that builds up in that area, that vertebral artery can get affected. And that could be an emergency. It also just lead to some bizarre symptoms like dizziness, and feelings of nausea and other things that would be tied into similar, like sympathetic or intense stress response, because there's so much protection when that's affected. It's and that circulation is running right into the brain. All right, so let's look at some of the muscles that are involved around the neck. So first we have the anterior muscles, or the muscles in the front. So let's zoom in here. We will add the first layers of muscles here. So we have the deeper muscles here. I mentioned before the hyoid bones. So you got your suprahyoids. I won't show all these, and you get your infrahyoids, but there's just a bunch of different muscles that are have hyoid in the name. But generally they're separated into the supra and infrahyoid muscles. And then we have, I'll add these in now, and we can take some of the muscles away, but the real superficial muscles in the anterior compartment here are your platysma. So if you were to make a face where you really tighten the neck, which looks like a funny face, that's the platysma that does that work. You take that away. And we have this sternocleidomastoid, which is an important muscle for a variety of reasons. You can see the attachment points here. You have one on the knob on the back of the skull called your mastoid process, which makes it part of the name, sternocleidomastoid. That's one attachment. And then sterno means sternum or chest bone. So you got the attachment on the sternum, and then cleido means clavicle. or collarbone, so you have the other attachment on the collarbone and clavicle. And why this is an important muscle. It's a very superficial muscle and can start to do a lot of work when we don't have great head positioning, or even because of its attachments on the sternum and the clavicle, could be involved in accessory breathing, which I'll discuss later, where we're trying to create more expansion for the lungs by moving the sternum up and moving the clavicle up. And we're using this muscle for doing that frequently. That's going to lead to a lot more activity in the neck than we need, and that can lead to some pain in the area. So that's an important muscle through there, and it's very easy to palpate. If you can find where your collarbone is right on the inside, you can find where your sternum is. You can usually grab the meat of this muscle on its attachment, both lower attachments, then you can trace it to that mastoid process that's around the skull region. All right, so if we look more on if we go deeper and we look at the prevertebral muscles, so we take some of these muscles away. And if you look back here, you could see this rectus capitis anterior, which is another prevertebral muscle. So you have the longus colli right there, and then over here you got your rectus capitis muscle, and these are just right on the front side of the vertebrae there, so they're often called prevertebral muscles. The paravertebral muscles, and again, these are important ones. I alluded to this earlier. We're looking at your scalenes here, so center that. So this is the posterior scalene, the most rearward scalene. You can see that attaches to the second rib down there and then attaches up here into the neck. We also have the middle scalene and the anterior scalene, and they both attach to the first rib, and then the other attachment is into the neck there. So those are often called the paravertebral muscles because they're off laterally to the side, but they're attachments at the ribs. Again, they'll pull up on the ribs if we're breathing in a manner that is very accessory in nature. We're not using our diaphragm as well as we could, and we're tending to use more of a accessory pattern for breathing. We're going to start to move the ribs up using these muscles, as well as the sternocleidomastoid, which I pointed out before, and really any muscle in the neck that has an attachment on the ribs or the sternum, the collarbones, can be used to help breathing in a manner that is not necessarily the most efficient, but we do it quite frequently, especially when we're stressed or when we're just not very mindful of using our diaphragm in a way that's a little bit more efficient. And we'll talk about that a little bit more. Finally, we have a bunch of vertebral muscles. So basically, these are the ones that are just on the backside. The semispinalis capitis, we have the splenius muscles. So it's just any of these muscles that are running down the spine that attach to the neck. The more important ones are certainly not more important, but more superficial and well-known muscles are your trapezius, your upper trapezius. You can see the attachment to the skull, and then it's actually not a muscle on its own, but it's just the upper portion of this big trapezius muscle, which actually goes down into the mid to lower back and then goes across into the shoulders. So this muscle just has so much function through the body, but the neck is certainly part of it. And the superficial nature of this muscle is important because oftentimes it can become a default muscle for function when other muscles aren't doing their job as well, or there's an imbalance or a substantial imbalance throughout the body. The other thing that's notable about the upper trap, along with the sternocleidomastoid, which I showed earlier, is that there is a tendency to create a lot of protection at the neck from these areas, and that's because they're innervated by cranial nerves, cranial nerve 11, and that basic function there is to protect the neck. So you think shrugging the shoulders is closing the space between the shoulders. That's what the function of the upper trap is. And then the sternocleidomastoid is to flex the front of the neck, basically protect those vital structures of the arteries, veins, and neurology that I showed earlier. So you get these two areas that the default mechanism for our body when it feels under threat is going to be to use these muscles quite a bit. And that's going to create this feeling of shoulders getting closer to the ear to close down the space of the neck to protect it. If we take that layer away, we can look here at the levator scapula, which has an attachment to the top of the shoulder blade and then into the neck. So again, an area that can lead to some pain, especially if the shoulder is riding up, and the shoulder blades are riding up more than we want them to. And we'll talk about some of the biomechanical relationships, which may default us to using some of the more superficial muscles and also some of the muscles that can close down that space between the shoulders and the neck. And oftentimes it's for protection, but the protection response gets out of whack. And we could broadly state that for any type of pain response that becomes chronic is that our body's willingness to protect us is going overboard, and we need to be able to demonstrate some type of control elsewhere through the body to teach our body that it can let us go a little bit and let that protection response calm down, and that in turn will allow us to feel less pain. So as we get back to the presentation here, so let's think about some biomechanical relationships. Now that we've seen the anatomy, we can see how close everything, how related everything is. We could also understand how some of that anatomy gets injured. All right, so the first biomechanical relationship to consider would be how joints, nerves, nerve roots, they get compressed. Basically, the joint gets a little closer together. The bones that make up the joint get a little bit closer together. The nerves that might be running through the holes made in the joint, the foramen in the joint, there may get some compression as the joint gets a little bit closer together. So we have to be aware of that relationship. And oftentimes these relationships are dynamic, not static, not anything that is not changing and needs some type of intervention where the structure needs to change. But we have to understand that at any point in time, we are looking to compress, we're looking to expand, put tension on some of these tissues. But sometimes biomechanical relationships are such that we get more compression than we can balance out with some of the other competing movements or competing relationships in the body. And that becomes part of the problem. We have to figure out how do we decompress for longer periods of time throughout the course of our day. And the same thing could be said about the next biomechanical relationship, which would be tension, which would be the opposite of compression. Is we're putting a pulling motion on some of these nerve roots, some of these peripheral nerves. Just could be based on our static posture, could be based on some muscle imbalances throughout the body, but that there is some type of chronic tension being put on some of these structures. So our goal would be, how do we balance that out and not take all the tension away from the body, but we want to have a give and take. We want to have a variability of the stresses that our body takes. Guarding becomes something that can create compression or can create tension. I think is a huge part of neck pain. And that's basically where we have a high resting state of tension in the body. But that tension could be a muscular action that is actually pulling our shoulders closer to our ears, which could be creating an underlying compression. And again, this is protection oriented, where it's our body perceives a threat and is creating this high resting state of tension to try to protect. And I think, again, that leads to some compression, some tension, but ultimately, we can't stretch that away. And we can't really have a surgery necessarily to decompress that takes that away, because what we have to do is teach the body to not need that protection. So we need to share the load. We need some different strategies to have the individual who's experiencing pain find safety. All right. And then irritation will come on if there's compression for too long, if there's tension that's too aggressive or for too long, and if the guarding response is too great or going on for too long. And irritation is just basically an immune response that's accompanied by inflammation, and it produces pain. And irritation is usually when you're feeling pain in the moment, when the pain is at the worst, there's some type of irritation. It's a general term. And I think inflammation becomes the more biochemical, kind of anatomical term that we'll think of that is going to produce that pain in that moment. But inflammation is not a bad thing. It is part of the immune response, a very necessary part of the immune response. So this irritation should be fleeting, but it can be very severe when it's there. And I think sometimes what happens is we get caught in an orthopedic narrative of, as I like to think of it, is we have an irritation that's acute in the moment, and then we might have episodes of this, and then we start to seek out some type of diagnosis that we can tie into the structure, that we have a herniated disc, that's why we had this irritation. But the irritation can come and go, where the herniated disc or the arthritis that one might see in an X-ray or MRI will not come and go. Well, it'll be there more statically. So there's a disconnect there between this dynamic irritation and something that we might see more statically on a picture. But what ends up happening is we stop thinking about it as this dynamic thing that can change, and we think of it more as, okay, now I have this diagnosis that is chronic, and there's not much I could do about it, or I have to get some type of surgery, or I have no hope of changing the irritation. And so I think it's important to appreciate that no matter what the structure that we have in our mind, that the pain that we're experiencing tends to be more dynamic than any structural presentation. All right, so this irritation idea is really important, because at any moment in time, we could use that as our feedback for what we want to do more of, what we want to do less of. So if something's causing more irritation, that gives us information. So we don't want to run away from it. We also don't want to just make it worse, but we want to appreciate it, learn from it, and be curious about it, because that's going to tell us what to do in any moment to not have it come back. And then we get some information, we get an education on how to help ourselves. So common presentations that we'll see around neck pain, you get the stiff neck, which is generally pain when moving the neck. We get the weak neck, which is pain or fatigue when trying to hold the head up. The guarded neck, which talked about is pain at rest, and often worsening with static postures. So this would be where the neck is overprotecting. Radicular arm pain, and it's a very specific pain presentation from irritation of nerve roots that are located within the neck. All right, so what's important about the radicular arm pain is that it actually follows specific pathways down the arm. All right, and the other thing is that it may be accompanied by a loss of muscle and reflex inhibition. So the worse these injuries become, it actually becomes less of a pain thing and more of a loss of muscle function or loss of reflex function. So that's important to understand. And again, the irritation of the nerve root is usually what causes pretty extreme pain, not so much a compression of a nerve root at any moment or a pinching of the nerve at any moment, but it just happens to be how acutely irritated that nerve root is. Because you can have that irritation go away, the pain really calms down, but you get an image and you still see the nerve is being impinged upon by some structure, whether it's a disc or something up the chain around the neck. So again, important to not look at the pain and the structural presentation or the structural diagnosis as the same thing. And what we're really concerned about in these cases is there a loss of upper extremity function? Is there a weakness in the hand that corresponds to these different nerve roots? Numbness and tingling will often be accompanied as well. That is more of a sign of compression in the moment, but it doesn't necessarily worsen over time. So every presentation is a little bit different there. There's people that can have numbness and tingling for, their whole life, and it doesn't worsen. And oftentimes it doesn't have to limit your function that much, just becomes uncomfortable. And oftentimes activity is better than kind of letting it go and can change the sensation, but it's not the same thing as having the irritation, the severe pain going down the arm. And it's not the same thing as losing function in your muscles or reflex function. So all of those have to be assessed separately and certainly they have, the seriousness of the injury is different depending on what is found there. Radiating arm or scapular pain is different than radicular pain, where that's more of the pain in the neck is just starting to spread. It's more nonspecific, starts to move downward from the neck into the shoulder blade region. It could be down into the arm, but not in a specific pathway like the radicular arm pain is. And then another presentation that less common, but actually my mom called me recently and reported some of these symptoms. So I think she was dealing with a little bit of this. There's T4 syndrome, which is this bilateral numbness pain that goes down the arms, but it can be in a glove-like type of pain. So it's not specific to any one pathway, but it tends to be bilateral as well. She was ill and recovering from some type of flu-like symptoms. And I think part of that stressed out the nervous system for her and led to some of these symptoms. But again, you can see that with just having increased stress in your life. Oftentimes an acute physical stress can promote this. And I think that in my clinical experience, there's some relationship to the thoracic spine having a little bit of rigidity and starting to get a little kyphotic, where there is not as much motion in that area where the sympathetic ganglion are. So part of the strategy here for decreasing symptoms would be to do whatever we can do to decrease the stress response in any moment. If there's an illness, sometimes it's just getting over the illness. Getting motion, though, in the areas that aren't getting motion. So static postures don't tend to be really good for this. And try to get a little bit of rotation and motion throughout the thoracic spine and throughout the upper extremity as a whole. So nerve gliding type movements, which are arm movements that encompass it, basically every joint of the upper extremity, become useful in these presentations. So for specifically looking at the presentations of the radicular pain that I was talking about before, if it's cervical level 4, we're going to look at the area of the outer shoulder, which would be sort of like your upper trap region. Cervical level 5 is going to be more your outer arm or the deltoid region. Cervical level 6, it's the outer forearm, but it also goes into the thumb and index finger, and that's kind of how you can differentiate it out when it starts to go on thumb or index finger. Cervical level 7 will be the middle finger specifically, so that's how you can differentiate that out. And then cervical level 8 is the 4th and 5th finger, so into the pinky side. And then if we move up into the inner forearm or the pinky side of the forearm, we're starting to look at thoracic level 1. And basically, some injury is happening at that specific nerve root when you start to have the symptoms move into these specific pathways. So now we've discussed common presentations, we can start talking about common treatment approaches. So as I mentioned, the cervical spine is very much tied into protection. So our number one thing is to do whatever you have to do to calm the pain down. So medicine, depending on how acute the injury is, like if it just happened or if somebody's having very acute irritation of a nerve root, I'm referring this person for some medicine if they haven't got it already from their physician. I'm happy to help them get them started in the movement process, but I've found through experience that they will not do well without medicine early on. So respect medicine when you are in a acute episode of pain, especially if there's acute arm pain involved. But even if the neck pain is just got injured, maybe there is chronic symptoms, but the episode of pain is increased and new, I would go with medicine. I would go with support. So cervical collars can be quite useful in the first day or two when you have a specific injury. And that doesn't mean you have to wear it all the time. That doesn't mean you have to be afraid to move the neck. But because the neck muscles are so involved in holding the head up, it's hard to rest them unless you're going to just lay down all day. And so if you're even sitting up and checking your email, looking at a computer, watching TV, when you're actually resting and you're trying to rest, it could be useful to have some external support like a cervical collar. Then you could take it off and purposely try to move the neck. But it also can be useful if you want to actually get a little bit of exercise elsewhere in the body, that you protect the neck, to support the neck so it doesn't feel like you're so guarded and you're so protected. And then the circulation that you're getting with exercise elsewhere in the body can actually help, and then you don't feel like you have to wear the support as much. Any type of relaxation technique. So we'll talk a bunch about breathing. And I think one of the most underrated interventions for neck pain is to change the way that you're breathing. Use breath control exercises or just bring mindfulness to your breath and imagine it as a way to shift pressure around the body when the neck, and the neck is generally saying anything above the shoulders is bothering you. This could be headaches as well, that I think any type of relaxation and breath control work play a huge role. All right. And then pain-free movement, as I was mentioning, you can support the neck, move the rest of the body as much as you can. And oftentimes that becomes quite useful. Number two is just get the neck moving as much as you can. You can do this after the first, 24 to 48 hours if it's really bad, and while you're supporting the neck and, having the medicine kick in. But I try to get that happening as quickly as possible, and having, number one, calm the pain down and get the neck moving, working together, where, again, I'll support the neck when I'm trying to relax, but then I'll purposely take some support off and try to get that neck moving in a way that's very safe and the person feels that they're ready for. All right, so we could break the get the neck moving down into, trying to decrease the fear of movement and also get any chronic tissue tightness, which is very common within the neck, to decrease pressure in the area. So if you're not used to moving the neck in very specific ways, right? Like after a while, we start to fix our gaze in front of us, looking at computers, looking at screens, driving, that we don't have to have our neck move in varied ways too often. So it could be a very useful thing to gradually just start to get people to move their neck, to rotate it more, to flex it more, to extend it a little bit more, just within whatever their pain tolerance is in any one moment. And it just starts to decrease some pressure in the area. The other thing that you tend to see is that it's very easy to limit motion from the neck by moving from other areas of the body. So sometimes we have to really lock down some of the other areas. So we've probably all been in that situation where we have some pain in the neck, but we still want to turn, we still want to drive. So instead of turning the head, which really hurts our neck, we just move our whole body. But we're still able to function that way, but we're just not moving from the neck. And before you know it, that becomes almost normal. And what happens is that you start to lose the actual joint motion that you have in your neck. So you get this chronic tissue tightness, and then you get this fear of movement on top of itself. And then that leads to compensations that constantly just keep limiting the neck motion. So what we have to do is understand what compensates, where we compensate from. We got to limit those common compensations. And then this will increase the relative motion in our neck compared to, say, moving from the shoulders too much or moving from the thoracic spine too much. The other thing we want to look to do is share the load as much as we can. So if we have too much movement from the neck, it might be due to the inability to move from some other areas. So sometimes we need to actually be asking for more. If we're trying to rotate and turn, we don't want it to come all from the neck. We want to move from the thoracic spine. We want to move from the pelvis. We want to move from the hip, and then have the neck join that process as opposed to the neck doing all of that process. So combining neck motion with motion from other areas of the body, very important. Talked about neural tensioning and neural gliding before. We try to isolate certain peripheral nerves that I showed before, but just the general idea is that we are including the nerves in stretches of all the tissues within the upper extremity. So these neural tensioning techniques tend to incorporate motion from the neck, motion from the shoulder, motion from the elbow, motion from the wrist, and motion from the fingers each time we move, which tends to be a very valuable thing for sharing this load. And then finally, we want to let the neck relax. So static positioning and increasing levels of emotional stress will tend to create this tension in the neck that is almost constant. Even when we're trying to lay down, we're having a hard time letting our neck relax because our posture doesn't allow us to actually have the neck rest without having, the right type of pillow and things like that. So it becomes really important to appreciate what are the things that are going throughout the course of the day that make the neck work too hard. And I mentioned this several times now that it's not a conscious thing. Oftentimes it's a very unconscious thing that we have to be mindful of, is that our neck is going to work when we're at rest more than probably any other anatomy that we have in the body, because it's trying to protect our head from collapsing forward. So that we have to use it to hold up our head, but it also is protecting the vital structures of the neck, even when they don't really need protection, because that's sort of a default mechanism there. And then depending on how we're breathing, if we're not really focused on our breathing and we're hyperventilating more than we need to, that's usually going to be some of the muscles within the neck that are responsible for that and for getting the lungs to expand, at least the upper part of the lungs to expand. So being mindful of how we're breathing, which we're often not if we're in the throes of our day, that's also going to have an effect on how much tension that we have in the neck. All right, so we'll finish with just a discussion about breathing, because it's so important when we're talking about neck pain. So neck pain and inhalation, what we're looking for is an expansive inhalation as much as we can, which is inhaling in a manner where we're widening the diaphragm to produce an inward to outward cascade of pressure. So basically the volume increases inside the body from the center out. All right, so as the diaphragm contracts, the middle of the diaphragm basically pushes down, the wings of the diaphragm get wider, and it creates a cascade of pressure that just expands our body throughout. This allows for a slower increase of volume throughout the body. So it allows for longer exhales and therefore less total breaths. The opposite of this, or the counterpoint, would be the accessory muscle inhalation. And this is where the muscles that are attached to the neck, the upper ribs, the clavicles, we showed some of those in our anatomy discussion. They pull upward to provide expansion of the upper rib cage and lungs. The volume increases up near the neck and shoulders, but it decreases down lower near the abdomen. So this tends to promote hyperventilation. There's not as much time to take an inhale, so you have more breaths per minute than you otherwise would, certainly compared to the expansive inhalation. And then you also have increased neck and back tension, because those are the muscles at play that are doing a lot of the inhaling. On top of that, there tends to be a decrease in lumbar stability, which is lower back stability, because not getting as much of this expansive pressure down lower from the diaphragm down into the guts down lower where the lumbar region is. There's less intra-abdominal pressure, therefore there's less stability in that region. If we're looking at the exhalation, it's sort of the opposite of what we were talking about with the inhale. What we're looking for is a compressive exhalation after an expansive inhalation. So a compressive exhalation would be exhaling in a manner where the diaphragm narrows upward, the center of the diaphragm narrows upward, and this creates a pressure release from outward to inward. It's usually following an expansive inhalation, and then the volume is going to decrease evenly towards the center. So we had that expansive inhale where there was a nice slow volume increase throughout the body, and now we're decreasing the volume evenly towards the center with this compressive exhalation. And the duration could be extended in a variety of ways. So we could slow the release of pressure via closure of our glottis, which would make more of a sound, the lips, which would make more of a blowing sound or a pursed lip sound, or the teeth, which would make more of a hissing sound. All of these are ways of slowing down. And then there are also ways of pressurizing the breath if we'd like to, which increases the intensity of it, which could be useful for strength training or certain type of movement endeavors. If we're just trying to relax, we just want to slow the breath down, but we're not trying to pressurize it as much. So the compressive exhalation, much like the expansive inhalation, allows for longer breaths, so longer exhalations, which allow for a greater relaxation throughout the body and more time not inhaling, basically. The paradoxical exhalation, which will couple with the accessory inhalation, is you're exhaling in a manner where the abdomen now moves outward to force air out. So that's going to be the opposite of the compressive exhalation, where you've already expanded outward during the inhale. Now you're compressing relatively inward, where the paradoxical exhalation, because we had that accessory inhale that pulled everything upward, basically made us skinnier in the abdomen, increased the volume upward at the top of the lungs into the shoulder and the neck. Now in order to breathe out, we actually have to push our abdomen out. So again, this usually follows an accessory inhale, but it's an inward to outward force, and it's usually of higher intensity and it's shorter duration. So it promotes more hyperventilation because it's more difficult to extend out the length of that exhale. And then it's a more intense pressure outward, which can promote things like hernias and herniation. So another common presentation with neck pain, or a common action that may lead to neck pain, would be overhead activity. And this can happen because of imbalanced action of the muscles surrounding the neck, shoulders, and the trunk. What we need to look to do is share the load between the rest of the body, the lower extremities, the core, the shoulders, and the neck, which will allow for less neck stress during overhead activity. So basically, if we use more of our body, then less will be asked of the neck. If we improve shoulder motion, that tends to also help too, because if we're limited in shoulder motion overhead, which is very common for most of us, we have to, we'll get the weight overhead, we'll get the load overhead, but we got to start using other parts of the anatomy more than we want to. And oftentimes this becomes the neck. We'll start to shrug up a little bit. We'll use the scapula, and then the spine will arch the back more than we would otherwise want to, instead of pressing the load directly up. So we don't necessarily have to have perfect shoulder range of motion. I think that sometimes gets overstated. But if we are having some issue with our shoulders or our neck going overhead, that's the first thing I would look to do is, can I get more out of my shoulders? Can I get more motion there? Because there tends to be a lot of motion to be gained from the shoulder, and then the neck will take less stress. But we still want to think of it as a load sharing idea. Now, we're not trying to do it all from the shoulders, but oftentimes we have a long ways to go with our shoulder motion. So that's when we start seeing some neck, scapular, and spinal issues with this overhead motion. And the neck pain and posture. So the neck musculature, as we know, supports the weight of the head. It's also very much involved in this hyperventilatory breathing and for protection, just in general when we're stressed. So static postures, they call on more sustained action from our postural muscles. So you can think of it, the greater the head is in front of the distance in front of the line of gravity, the greater the load on the muscles on the back of the neck and the postural muscles. Also, our gaze is tied into how our postural muscles function. So the more fixed our gaze is, it creates more sustained action in our postural muscles. And, if our gaze is actually intensely focused for a long period of time, it can actually be creating more intense load on the postural muscles. This is not to say that there is a perfect posture. To me, there's not a good posture. There is just a posture you're in too long. Just try to vary it up a little bit more. Problem is that a lot of the actions that we do throughout the course of the day do not call for varied postures. So we have to be mindful of it. So set some timers, set some alarms to break up this static positioning and break up not just the posture, but the gaze, right? So if you're moving around, but you're going and you're exercising and you're still like reading a small screen, that may not give you what you're looking for as far as taking tension out of the neck. So get outside. Sometimes just sit and gaze in the distance. That's why one of the reasons that I think it's so calming to go around water, because you can gaze at a horizon, you can look in the distance, and it's a different type of tension on the neck and all the structures that are near the skull, the neck, and the cranium. And then finally, we talked about this quite a bit already, but neck pain and stress. So a heightened stress response, it moves us towards increased tension and circulation to the superficial muscles that promote aggressive action. All right, so it leads more to hyperventilation and actions that protect the vital structures of the face and the neck. There's also decreased circulation in the areas of the internal organs. So digestion is not a priority when we're stressed. So we might get some neck pain and then also some GI distress. A heightened stress response also tend to lead us a little bit more towards impatience, aggression, and anxiety. So just looking at interventions that you want to counter that, we look at, number one, a breathing practice that moves us away from hyperventilation. Rhythmic movement can be quite useful. So I like to think of aerobic exercise, if it's done well, that it's naturally rhythmic movement, because we're not working too hard. We're just allowing ourselves to go longer. And this is why I think there's a value in this like zone 2 type of training, not just from what's going on cardiovascularly, but that there's a natural rhythmic action to be able to do something longer. The better we get at doing things longer, which is, kind of inherent to aerobic exercise, that we have to get better at using our body in a rhythmic way. That's sort of my thesis or my hypothesis at this point, from doing it myself, but also working with clients with that there's a difference between high intensity interval training, which has plenty of use, but it's not the same thing from a relaxation response, especially when somebody's in acute pain. How being able to move in a way that you can move for longer periods of time comfortably, trying to figure that out can be very difficult when people are in pain, but when you find it, it can be better than any type of pain medicine in my experience. So trying to find that type of rhythmic movement, and I think that gets tied into aerobic exercise quite a bit. It could also be any type of rotary or reciprocal motion. So a lot of aerobic exercise does have a reciprocal motion component: swimming, walking, running. If you're the better the efficiency is, oftentimes the better the reciprocal or rotary motion is. We could also look at compression, which would be massage, creating a deep pressure into your body. Weighted blankets sometimes are very calming for people, and pressure therapy, which to me is just the term I use for self-massage, and being able to tolerate a little bit more pressure over time. So going through a process where you actually want to gradually be able to tolerate pressures that you couldn't tolerate so well before by using firmer balls progressively over time. Something that I think is quite useful, and sometimes you need a little bit of supervision for. And then finally, meditation could be mindful meditation, which is just, to me, just the idea of paying more attention to the present moment. And then contemplative, which it's you're paying attention to the present moment, but you're also contemplating things like loving kindness, gratitude, patience, right? So that would be the counter to this idea of when we're stressed, we tend to, if you really are in a state of fight or flight where your life is in danger, it's not the time to be patient. It is the time to be aggressive, and you should be anxious because you want to get the hell out of there. You want to save yourself. But most of the time, we realize that when we're feeling all those things, our lives are not in danger. But sometimes our stress response doesn't know the difference. So meditation gives us space, no matter how we do it, from those natural reactions that we might get when we're stressed. And just by giving us that space, a lot of times it can make a huge difference. One thing I will say, and with my experience with meditation, it's just like any other practice, though. It's not a pill. So you got to give it time, and you got to prioritize it a little bit and make it a practice like you would make exercise a practice, where you're not going to be getting all the fruits of exercise in one session. And you really aren't going to get the fruits of exercise if you did it for 2 years and you stop. You have to do it for life. You build on it. That's how meditation is in my experience, where it's something that you're constantly building on. And it's really a hard thing to define. But if you can kind of get it generally to mean that you're moving away from impatience, you're moving away from aggression, you're moving away from this fight or flight response, I think it can be a useful way to frame it. So hopefully that was useful. If there's any questions, don't hesitate to reach out. Neck pain is certainly something that can be very scary for people because it does come with some of these symptoms that move down to the arm. And it's also very tied into our stress response and our protection response. So understanding that how much of the pain that you might get in your neck is going to be tied into some of your other behaviors in life, and some of the ways that we deal with stress, I think could be quite useful way to frame how to get better from this. See you next time.